will be performing NG tube insertion, irrigation, and removal. My name is Sheena Knudsen, and I have placed my patient in semi-Foulier's position. I have then let them know the procedure, and if he had any questions, I would have answered them. The chucks, the tissue, and the basin would be all here in case he has a large emesis. Next, I would assess his nasal area. Is there any polyps, obstructions, or deviations? Then I would assess each nostril and determine greater airflow. I determined the right nostril would be the best airflow, and he has no history of nasal surgery. Next, I would have to determine the length of the tubing, starting from the tip of the nose, down to the earlobe, down to the zoophyte process. I would also have a cup of water here to provide him while he is swallowing water during the procedure. So then I have already secured my tape where the stomach should be resting in the xiphoid process. This is a rough estimate, and we would be doing some checking later on. Then I would turn on the suction to low intermediate. The white tip of the tubing would be connected to the suction. So now I would connect my suction. Lube the first 4 inches. I would have assistance with the water, and I would let the patient know it's time to get started. I can insert the first 3 to 4 inches, give him a break, insert more while he's able to swallow until he starts to gag. Then we notice there might be obstruction. So if there is an obstruction, but this client, he's doing much fine, but we just want to make sure we tell him to keep his head tilted forward during the procedure, and we would check his throat by asking him to look forward. We notice the tubing is coiled, so we would withdraw the tubing, uncoil it, then keep inserting it. Now we get to the spot where we have indicated the stomach should be lying, and we have done the appropriate tests to test that. So starting at the bridge of his nose, we would use a split in half tape. Then after putting it on the bridge of the nose, we would turn one side of the tape around the tubing. Then we would turn the other side, so it's securely in place. Making sure we hold on to that tubing the entire time. Next, we are responsible for checking the placement. So, we get a piston full of 5 to 10 cc's of air first, unhook the anti-reflux valve, hook this up, insert the 5 to 10 cc's of air, which prevents the tubing from sticking to the side of the stomach wall. Then we would actually keep it connected. We might get a new piston, but we would withdraw 5 to 10 cc's of stomach contents, disconnect, put it back blue to blue. Then we would have a pH test strip, and at the same time, let me demonstrate that again. We would disconnect, insert 5 to 10 cc's of air, aspirate 5 to 10 cc's of stomach content while listening to the xiphoid process and the lower upper quadrant, making sure we hear, just say this did not get disconnected, making sure we hear a gush of fluid, or gush of fluid of air coming in. Well, we put the 5 to 10 cc's of air. Then we would withdraw 5 to 10 cc's of stomach content, hearing the gush. So we know we're in the stomach, but we still want to test the pH, even though we still hear the flushing sound of the air going in. Then we connect blue to blue. We'd withdraw the 5 to 10 cc's on a pH stick. Normal is 0 to 4. He is in the 0 to 4 range, so we are in the stomach. So that's insertion. So now, let's say the patient is having a hard time getting his fluids through his tubing. We need to irrigate. So we would have to insert. We would have to disconnect the NG tube, or we would have to disconnect the anti-reflux valve, insert 5 to 10 cc's of air. We would hear that gush. We would disconnect, get 5 to 10 cc's of water, or 30 milliliters, 30 cc's. After the 5 to 10 milliliters, or 5 to 10 cc's of air, now we insert 30 milliliters of water, and we start to pump it. Great, we have dislodged it, so we're able to connect the anti-reflux valve. Now, let's say we've cleaned our hands and we've donned new gloves on, clean gloves. The physician orders removal. So now to remove it, we have to locate and assess vowel sounds in all 4 quadrants. We hear vowel sounds just fine. So then, we disconnect the anti-reflux valve, we insert the 5 to 10 milliliters of water, or air, to dislodge the lining, or the tubing from the side of the stomach. Next, we would have to locate. So then we would keep the plunge into the tubing, and we would withdraw 5 to 10 cc's of air, stomach fluid. And when we were inserting the air, we would still, like the other times, listen to the left upper quadrant to make sure we hear gush. So we did hear the gush. Then we withdrew 5 to 10 cc's of stomach content to test the pH again. So we disconnect, reconnect the anti-reflux, we test the pH. It's in normal range, 0 to 4, so we are in the stomach. So now we inform the client that we can remove the tubing. We want to turn the suction off. We want to remove the tape. Now, with a hands over hands motion, using both hands to control the removal, we would then dispose of the supplies and contents. Then we would perform proper oral and nasal cares. We would clean his nasal area, and we would then document. That's then the procedure. Thank you.